The dog had a small vulva and looked pre-first season, so the incision was made slightly back from the umbilicus. The fat was cut out rather than blunt dissected, helping clamp placement and visibility. The linea alba is identified and lifted high, keeping the stab incision safe. Try and keep the scalpel handle parallel to the dog. The incision site is lifted high and extended with scissors along the linea alba. I have realized something is not correct. I have missed the linea alba by a few millimeters. You can see I have not entered through the peritoneum, which you see still attached to the linea alba. To rectify this, I need to cut the peritoneum as close to the linea alba as possible. I keep it raised so I can't damage abdominal contents. I now can enter the abdomen. I slide my finger down the abdominal wall. Keeping the abdominal contents behind my finger, I touch the vertebrae and slide back using my index finger as a hook. The uterus is exteriorized and I have to push down on the body to grasp the ovary. I then transfer the ovary to my right hand and use my left index finger to break the suspensee. You can pull on the ovary as the ligaments are intact, but if you pull too much on the uterus, it can snap. Remember, don't break the renal ligament. We leave this to protect the ovary and vessels. The suspensee runs round the back of the kidney. Push down at the insertion to the rib or as close to it as possible. Remember, breaking the suspensee deep down prevents ovarian vessel damage. Make the window as deep as possible as we want to place the millers deep. Find an area which is see-through with no vessels evident. Make sure you are well away from the major ovarian vessels. Place the clamp, preferably an atraumatic carmolt, across the ovarian pedicle. I tend to walk the clamp down rather than push it down hard, and have the clamp about an inch or more below the ovary. Keep some tension on the ovary while doing this, unless you have accidentally broken the renal ligament. Now separate the uterus for better visibility. For health and safety, as well as better control, I cut with scissors and only use the blade to cut the ovary off. Now form your millers, keep it loose and then nudge the millers deeper. Once deep, rotate the clamp using forceps so when you tighten the ovary, the ligature stays low and isn't pulled up. Remember, these knots have to be super tight. The ovarian vessels are under high pressure. If the miller knot cuts through the fat, don't worry, this is a good sign. Always make them as tight as possible. I prefer PGA as I have never seen PGA cheese wire through. Now hold the ovary and raise the clamp. Ensure that the clamp is still clearing the ovary. The second millers can go in the crush bed, but this is not essential. Because we have separated the uterus and broken the suspensory ligament. We can check for bleeding now by releasing both clamps. If there is bleeding, replace the clamp and ligate again. If happy, replace the clamp and take the ovary off with a blade. Now make a window in the broad ligament as low as possible. Keep the uterine vessel with the uterus. Take care not to damage the uterine vessels. Occasionally I use scissors bluntly to extend. Place a surgeon's on the broad ligament. Unless it is thickened, then use a miller's. I rotate the clamp to ensure the ligature is not too close to the clamp. The uterus is large, we can easily feed up the other side. This dog must have already had a season. Again, hold the ovary in your right hand and place your left index finger on the suspensory ligament. Slide down to the insertion, feeling your finger slide past the side of the kidney. Keep the suspensory tense and push down with your finger as close as possible to the insertion. This side is thicker and harder to break when compared to the dog's right side. If pushing down doesn't work, I will try pushing up, low down near the insertion. And if that doesn't work, I break it in 2 pieces. Again, make sure you don't break the renal ligament. Now make a deep window in the broad, where it is see-through, away from the vessels. Walk down the ovarian pedicle clamp, so there is a good distance from the ovary. Place 2 clamps above the ovary and separate the uterus. Place your Miller knot loose. Carefully push it down and then rotate the clamp. And then tighten the Miller's knot. Ideally use a curved clamp as shown to rotate the pedicle clamp. See how I replace it with a larger clamp, as it's not staying rotated. If you have accidentally broken the renal ligament, it is better not to rotate the clamp. Now release the pedicle clamp and move closer to the ovary. Place the second Miller knot and nudge down. Remove the clamps, check for bleeding. Add another knot if unsure, and then remove the entire ovary. Tie off this side of the broad ligament, as done previously. Now we extend the uterus and can easily ligate it at the uterine body. A surgeon's is placed first, as less likely to cut through the uterus. As this uterus was edematous, I used catgut to further reduce the chances of cutting through. Next was a miller's, using PGA, and I keep the ligations fairly close. Following this, I used a 2-strand transfixing ligature, again with PGA. Use a strand without a needle and then place it through a needle. Check both strands are equal size and then pass the needle through the uterus. Cut out the needle and then check which strand goes with the other. And then tie off each side with a surgeon's. Now clamp and remove the uterus, cut at least 1 centimeter away from the transfixing. Do it so you don't leave the crushed bed inside the dog. Check for bleeding and then push the uterus slightly in and check again. Occasionally there is no bleeder because it's trapped between the muscle. But once released starts bleeding. We now close the muscle with a continuous suture pattern. Unis keep changing their mind about whether to include the peritoneum. But as I missed it completely, I include the peritoneum. I am concerned there is a slight hole in the muscle closure. So I add in a single ligation just to be safe. We now close the fat in a continuous pattern. To hide the knot we go deep superficial on the first side. And the superficial deep the other side and then tie off. Now I tie off with a surgeon's, which I prefer to an aberdeen. And then to hide the knot, I pass the needle cranial to the knot. And come out in the intradermal position. The intradermals are a continuous pattern. I try and leave a slight hole at the end for burial. It is essential to bury the knot. First, wiggle the needle through the slide hole. Come out a distance away by lifting the skin, especially if finished with an abdomen. Pull on the suture lightly and pull the skin over the knot. You should feel a tug or pop when the knot buries.